specific to respiratory viruses with fever, cough, shortness of breath, sputum production, headaches, sometimes anosmia, the inability to smell, and also majority, if not all patients, present with coexisting disorders. The most severely affected, for sure, are affected with comorbidities. The virus' primary mode of infection is to propagate by droplets. The droplets are illustrated in this diagram during intubation, during bag mass ventilation, but this can happen also during any other obvious procedure such as bronchoscopy or eventually tracheostomy. Next slide, please. One of the biggest difficulty is to try to distinguish the cases based on severity. We typically admit patients to a ward as opposed to an intensive care unit based on history, the presence or absence of radiographic abnormalities, people who are already hypoxic, but they are able to maintain oxygen on 4 liters of oxygen in nasal cannula. Some people use the curve 65 criteria over 2 to admit patients to the ward, and they particularly look for spatial consolidation of cases, not admitting patients all over the hospital, but in one particular ward. The monitoring of the respiratory status is critical, as we know that as the infectious process advances, more severe respiratory presentation may happen. It's critical to train and retrain staff on the emergency room department, on the ward, as well as in the ICU, to be familiar with signs of severity. When the patients are getting worse, hypoxia typically worsens. They present with altered mental status. They may have worsening pulmonary infiltrates and getting acute respiratory distress syndrome. Remember that intubation of patients at a high risk or with COVID represents a big risk for viral transmission to healthcare workers primarily. So measures that we can discuss needs to be put in place for that. Performing intubation drills and being familiar how to use the personalized protective equipment is critical. We try to avoid bag mass ventilation. Everybody in the room is well protected. A minimum number of individuals are present during these invasive procedures, and we try to respect standards of care. High oxygen requirements can be delivered in the ICU even prior to the intubation. We can come back to this. Yet we are discouraging delivery of oxygen through BiPAP machines. We prefer to intubate patients rather early if the trend is towards worsening of clinical status. Early extubation in these patients seems to be quite challenging. In our experience, we have not been able to extubate patients around the 8th or the 10th day, as is sometimes common to see in the ICU. Although the lung compliance is not bad in particular, we find that extubating of these individuals with diffuse lung injury remains very challenging. Next slide, please. The imaging presentation of COVID-19 is very interesting and important at the same time. On the left-hand side, this chest X-ray shows mild area of pulmonary densities in the lower lobes on both sides. On the right-hand side, the patient is much more severely affected, now is intubated and has bilateral diffuse pulmonary infiltrates, suggestive of acute respiratory distress syndrome.
Cho
Next
thấy là
slide,
bệnh nhân
please.
đang có cái tình trạng suy
It's
hô hấp
not
nặng.
everybody who presents with pulmonary
Tất nhiên là
imaging.
không phải
Maybe up to 40% of them don't have much
cái hình ảnh
abnormalities on chest
vậy.
CT, but the most common one are depicted here. These are patchy
Đây là hình ảnh
ground
CT.
glass opacities, not in one area of
những
the
cái
lung,
khoảng kính
but
mở.
diffusely
Chỉ có
throughout
trong khoảng
the
40% bệnh
five
nhân thôi, nhưng đây là những trường hợp
lobes. Next slide,
nhất.
please. The presentation can be quite variable.
Và
On the left-hand side, in that little square, you see an area of reticular abnormality. That is signature of COVID-19.
Cũng có thể
it could
khác
be
nhau.
presenting as crazy paving-like images,
có thể là
like for PAP on the right-hand side. Next slide, please.
Ở đây.
The pleural abnormalities associated with COVID-19 are quite common as well, and you see them very well depicted on the left-hand side at the top and the bottom part of the image. On the right-hand side, you see much more discrete area of pleural of linear opacities or a big ground glass opacity in the red square. Next slide, please. COVID-19 can also present as nodules that are partially ground glass and partially dense, with area of hypolucency as well. All kinds of presentations can be present and can be the true presentation of COVID-19. Remember that a large number of patients presenting with the infection remain asymptomatic, and they may have actually some of these rather mild pulmonary presentations. Next slide, please. Some patients present with lymphadenopathy in the mediastinum as represented by these stars, and being the only presentation in the airways. Next slide, please. This slide of a patient with ARDS is much more common and seen in more severe cases, with diffuse patchy infiltrates diffusely throughout the lungs. Next slide, please. On the pathological evaluation, we don't have a large experience, but early studies from Dr. Tian, published in JTO, demonstrates that some of these alterations in the lung are associated with an exudative infiltrate that's very loaded with proteins. We see globules and large protein globules on the B slide. And then on the D slide, you see areas of cellular infiltration of the virus presenting with viral inclusions that are typical of respiratory viruses. Next slide, please. Now, one of the critical areas in our pulmonary perspective is to look at comorbidities and how to predict who is likely to be more challenged with this virus. This data from China explains very nicely or illustrates nicely the comorbidities that are often seen. Chronic obstructive pulmonary disease being one of them, diabetes, hypertension, or the presence of a malignancy. The presence of one or two of these malignancies are associated with a much greater risk of mortality, which is also depicted on the slide on the right-hand side. When the patients eventually reach the ICU, the mortality rate of this virus remains extremely high and varies between 30 and 50%. Next slide, please. We typically assess severity also with some types of biomarkers. This may not be available everywhere, but when available, may help you categorize and stratify your patients for high risk. Those presenting with elevated D-dimer, CRP, LDH, elevated troponin, ferritin, or creatine phosphate kinase may be at higher risk. An absolute lymphocyte count that's low also is associated with greater risk. Next slide, please. Now, the treatment of COVID-19
cái điều trị về
I find it
COVID-19
most frustrating at the moment.
thì
The
tôi
reason for
cảm
this
thấy
is because we have
khá
seen
là
up to 170,000
khó
deaths in
khăn.
the world now, and yet a
Ở
respiratory
Mỹ thì bây giờ
virus for
nhiều
which we
nhất
don't have
của thế
effective
giới rồi.
treatment.
Và
We
hiện giờ
could
chúng tôi vẫn
stop the
chưa có một cái phác
presentation
đồ
here
điều
when
trị
we talk
đặc
about
hiệu.
treatment to say that there is none of them that are currently rigorously tested to be
Và chưa có một
efficacious.
cái phác đồ điều
And
trị
yet,
nào mà
we
chúng tôi
all
có thể
try
tự
to
tin
do
nói
our
là
best
được
and
thử
provide patients with
có
support.
hiệu quả.
Empiric treatment for pneumonia may be considered. Although we know that bacterial superinfection is uncommon, antibiotic therapy could be initiated
Có thể
early.
là những cái phác đồ điều
We
trị
also
viêm
know
phổi
that this
áp
virus
dụng
is
thì nó cũng
associated
không phải
with
là điều trị.
macrovascular thrombotic disease. And there's a question about using anticoagulation. Actually, guidelines currently
Cũng có thể là
recommend the
dùng
use of
vài
low
thuốc chống
molecular
đông.
weight heparin for DVT prophylaxis, and it may actually prevent also pulmonary vasculature disorder. How do we handle the fever? Well, NSAIDs have been questioned. The data is not out there totally to formally prevent us from using it. Acetaminophen may be preferred. Inhaled therapy for people with asthma or chronic airway diseases need to be still provided. We prefer metered dose inhalation as opposed to nebulized therapy to avoid contamination with droplets and propagation of droplets in the air and surrounding the patient. Remember that droplets can be visible in case they're loaded and they're big, but they can also be microscopic, not visible, and yet inhaled and infectious. Steroids, we don't have good data to support that glucocorticoids may be helpful in these patients unless they have obvious states of shock with adrenal deficiency. ACE inhibitors and statins have been questioned for their use, and yet we continue to use them if there is no reason to stop them medically, particularly based on hypertension or liver disease respectively. Immunosuppressive therapy, we try to stop them when we can, as we know that lymphopenia may be associated with more severe disease. Next slide, please. Now, there is a lot of hope in the treatment of this virus still to talk about. We know that the mechanism by which we want to interfere with this virus is based on this mechanism of infection. This is what the diagram on the left-hand side is showing. The virus enters the airway epithelial cells through some receptor, and you heard about the ACE2 receptor, which is used for internalization of the virus, interfering at any step within the mechanism of the viral entry, replication, forming a new structural protein, and assembly of the virus itself, all the way to exocytosis, are strategies to interruption and to treatment options. Now, what do we really have available at the moment? We've been talking extensively about hydroxychloroquine, who eventually inhibits some viral entry and endocytosis. Is there definitive data to support its use? Not as of yet. How about remdesivir? Remdesivir is a small molecule inhibitor that eventually prevents viral entry as well. This drug is being also actively investigated worldwide. There are risks associated with kidney function, but there seem to be some promising data coming out. Convalescent plasma is conceptually really interesting opportunity. People with the disease who have developed an immune response and improved and survived the disease, do they have in the circulation antibodies that may be protective to an infection when given to another matched individual? This is the hope for convalescent plasma, again, without definitive data, but with some anecdotal success and clinical
còn
trials
một cái bằng chứng
ongoing.
khác nhưng mà những cái dữ liệu
Similarly,
mới
for
nhất
the
thì cho thấy
interleukin 6
cái
inhibitor,
triển vọng khi mà
this
vết
inhibitor
thương này.
doesn't target the virus itself, but however, it targets the extensive inflammatory response associated with the virus. Remember that we are
Tất nhiên
sometimes dealing with the treatment of different diseases induced by this virus. The first one may be treating the viral infection itself and its infectiosity. The second treatment we are seeking is to treat inflammatory disease itself. When and how to use this medication and at what point exactly in the management of these patients remain subject of discussions. Now, I have not approached yet the obvious treatment, which is oxygenation of these individuals. There's a lot of controversy also around this field. We try to limit non-invasive ventilation, as we know the open circuit will favor droplet deposition in the environment. And high-flow oxygen may be, although quite an effective way of delivering oxygen at high FiO2, it may eventually worsen droplet exposure to healthcare workers surrounding these patients' care. Although that topic is very much debated and a subject of intensive studies as well. We talked briefly about early intubation, and ECMO could be, and yet I have to hear more about success stories, probably not easily available in low-income countries. Next slide, please. The challenges that we are facing are leading us to consider hospital management and prioritization of our strategies. How many beds do we have in the ICU? How many ventilators? How many ICU specialists, doctors, nurses, respiratory therapists? Is this type of intensive care affordable for low middle income countries? How do we prioritize access to an intensive care unit when the patient load overflows and overwhelms the medical system? Are they exact appropriate boundaries of age, of comorbidities, and how do we integrate patients' wishes? Is a subject for high ethical considerations and very difficult situations to handle. Next slide, please. I think that the bioethics brings us in a very humble place where we may not be familiar with this type of triaging of the ICU, at least not in the setting where I practice. This ICU triaging is very ethically complex and emotionally draining, and brings doctors and healthcare providers to very difficult questions. We always respect they're handling the best way possible these difficult situations, and the literature offers some guidelines on how to eventually consider triaging and prioritization in the most ethical manner possible. We need to consider physiological outcome prediction, and yet we know that the scoring is not particularly easily available or easily accurate, rather. Shared decision-making and attending of patients' wishes remains a priority and yet not always feasible. Providing the most good to the most people is the goal. And so we respect standards of fairness, duty, transparency, proportionality, and accountability. I think these ethical standards are really essential. And we have to understand the limitations of our resources, of the institution, and our commitments to the family remains the priority. Next slide, please. So at some point we have to make hard choices. And actually it puts yourself, healthcare professionals, at risk. What's the impact on yourself, on your health, the impact on your healthcare co-workers, We need to impose social distancing as much as we can, using sheltering in places, wear our PPEs as directed, and not trying not to deviate from it if at all possible. We need to take our PPEs off correctly, and most importantly, we need to expand our ability to educate the healthcare workers and the population in respecting isolation, quarantine, indications for appropriate testing, and moving from testing to eventually case finding, contact tracing as we call it, and isolation of people at the highest risk. Next slide, please. So I'm finishing with making the hard choices, putting yourself at risk, having impact on yourself and the healthcare workers, stop, spread the germs, and basic guidelines in prevention remains our goal. In pulmonary medicine, for sure, to prevent the difficult outcomes that we have been facing. Next slide, please. And next slide again. The key points I want to reiterate and emphasize is that we are dealing as in the pulmonary community as some problem we know well. It's a viral pneumonia, yet this one is particularly deadly when we have high-risk individuals with comorbidities. Droplet is the main mode of transmission, and we need to avoid it. We need to reduce aerosolization, wash our hands. And to date, humbly saying, there's no specific treatment available. We need to protect our healthcare workers and protect ourselves and our families. We do not want to abandon most evidence-based practices if we can. And we need to promote education and prevention, as well as facilitate clinical research for a field that is definitely in need for much more information to come to help combat this disease. Next slide, please. At this point, I'll end my presentation and be happy to take some questions.
Great, thank you so much, Dr. Massion. And I'll just reiterate that if you have a question, please write it into the chat function where it says chat at the bottom of your screen, and we will make sure that the doctor presenter receives and has the chance to respond to it. I know we're running a bit behind because of our technical difficulties, so we will start going through the questions. Dr. Massion, I know you received a few of the pre-registration questions, and let me just pass it to you for 1 minute to see if there are any of those that you particularly wanted to address, and if not, I'll move on to those that we've just received.
I think you should move on to those that you received. I think that'd be good.
Sure, absolutely. So one question in, when we evaluate antibody presence for possible convalescent plasma treatment, how well can we differentiate antibodies against COVID-19 from other coronaviruses such as MERS or SARS-CoV?
We can type the antibodies pretty carefully, and these are detected based on ELISA, pretty simple methods. So we need to be demonstrating the presence of antibodies that are specific to this virus, and that's easily achievable with minor technological guidance. And then when the patients have these antibodies, they need to be matched to the donor, the recipient, and then could be eventually given. There are protocols that are currently being not only tested on a clinical research standpoint, but broadly distributed to extensive number of sites who are able to run clinical trials and enter patients to enrich the clinical research in that space.
Thank you. Just moving on to the next few questions. In a situation of low resource settings, in your opinion, is it feasible to put one to put more than one patient on a ventilator if necessary? And if so, are there any different protocols to follow?
Yes, it is possible, and yes, it is challenging. I don't have any experience doing it myself, but remember that when we put two patients on the same ventilator, the patient's lung compliance and oxygenation need to be pretty matched to be able to ventilate them in a manner that would be sufficiently personalized for these two individuals. If push comes to shove, people have done it, but it is a challenging practice. I hear that even in New York City, people have not had to recur to that practice too often. But it is possible. There are definitely protocols that are available on the internet, and we can probably help you with to get these resources available to you.
Thank you. Next question. If I'm a healthcare worker in an institution where N95 masks are not available, but I have either a cloth or a surgical mask, how big is a difference is there in my protection from being infected?
Your protection from an N95 mask is about 99.5%, so it's very good. If you use a surgical mask that is well fit to you, the protection is about 90 or 95%. So you have a large benefit from wearing a mask at all costs. And remember that if you can, you should also put a mask on your patient's face, because the droplets are generated from the patient.
Are there any special invasive mechanical ventilation considerations unique to COVID-19, not typical of ARDS?
That's a good question. In my experience, it has not been that of a challenge, really, to ventilate patients, even with ARDS related to COVID-19, unless they undergo multiple organ failure, which may lead to end of their life. The mechanical properties of ARDS related to COVID-19 alone are those of an ARDS with relatively favorable lung compliance, requiring fairly high oxygenation level at the beginning, but plateauing pretty quickly and can be managed. The difficulty is to get off the ventilator and get this ARDS out the way. It is taking, in average, much longer of a recovery period for individuals who have COVID-19 ARDS-related infection.
Thank you. Next question. If you are triaging patients, what are signs that differentiate COVID-19 from a regular cold or any other upper airway viral infection?
Great question. There isn't any. That's the challenge. And we cannot take clinical presentation for granted. Even people who are symptomatic may very well present with the flu or with any other respiratory viruses. Another coronavirus is still a possibility. Now, some people have claimed that some symptoms may be more suggestive of it, like anosmia, losing the sense of smell, for example. But this is not specific, and many viruses cause this. So that's one of the big challenges of this virus, is that it doesn't really declare itself as specific in any significant way. And remember that before you become symptomatic, you are already replicating the virus should you be infected, and you are propagating the disease as well, unknowingly, which is the most deceiving part. And this is why it is very difficult to track these individuals who are infected and yet not yet symptomatic. How do you identify them is a big challenge.
Yeah, absolutely. Thank you. Our next question is, can you define early intubation and what should the threshold be?
That's a clinical question. And everybody who is
Lặn ống thở lỗ khí quản
involved in
sớm thì là như
intensive
thế nào?
care
Ngưỡng
knows how to address that. We typically address that by means of tracking patients' vital signs, including mental
thì mà chúng
status,
tôi sẽ
signs of severity with
những
increasing
cái bác sĩ hô
respiratory
hấp thì biết cái chuyện
rate,
này sẽ
oxygen
là
desaturation,
những cái
and a trend towards fatigue, not able to
biểu hiện sớm của bệnh nhân.
protect the airways, and eventually requiring intubation. We used to, in the ICU practice now, to use a lot of non-invasive ventilation to bridge patients to try to have them actually, you know, be able to being bridged to a space where the oxygenation is better delivered, and yet they get some support from the non-invasive ventilator and not requiring endotracheal tube intubation. But because of this non-invasive ventilation is prone to propagate droplets, we are recommending not to use it to great extent. High flow oxygen, I must say, in our hospital is used in the ICU to deliver oxygen to patients with oxygen desaturations. And some anecdotal data would suggest that high flow oxygen doesn't seem to increase droplet generation or propagation in the environment as much as any other technique. And maybe not much more than oxygen delivered by nasal cannula.
Nó sẽ làm tăng cái số lượng giọt bắn cũng như là tăng nguy cơ lây nhiễm.
The next question is, does the inflammatory response of COVID-19 differ compared with other severe viral pneumonias?
Đối với COVID-19,
I don't think we know very much about the pathology of the COVID-19 pneumonia as of yet. I showed a few examples of histological presentation of COVID-19. My impression is that it does not differ very much at all. If it's not that the virus seems to propagate from the proximal airway to the distal airway readily and affect all levels of the airway. Bronchial tree. Remember that there are 23 bifurcations from the trachea all the way to the alveolar space, and the entire tree is readily affected. It also is associated with a lot of mucus hypersecretion in many patients and an incoercible cough that is difficult to manage when people are on the ventilator on closed circuits that we try to avoid to open to the ambient air. So there is no really pathological pathognomonic features of this COVID-19 infection that I am aware of, and I don't think the field is aware as of yet.
Bệnh viêm phổi thông qua virus khác mà tôi được biết.
Thank you. Just going back to something you were citing before, a question came in. What evidence are you citing in reference to N95, 99.9% effectiveness versus 95% surgical masks? Can you go into a little bit more specifics about this?
I have a hard time going in more specifics than that. I think I read this, but I have not researched it myself. I think we can get the data from you know, a long-term experience of well-fitted N95 masks. There is a lot of excellent data in prevention of infectious agents in general. Now the face masks, surgical face masks, and a cloth being put in front of the face vary tremendously in the way they're fitted, in the way they're tight, in the way they allow the nose bridge to be sealed properly. And I think that the data around those is much less accurate. Now, a true surgical mask, well fitted, is supposed to cover you at about 90 to 95% from environmental pathogens and prevent you from transmitting outside. So I think there's a lot of data in that space that should be fairly easily searchable. And I can help you in the future if you want me to do it.
Và tôi có thể cung cấp thêm thông tin cho các anh chị.
Great, thank you.
Trong thời gian tới nếu cần.
The next question is, have you seen beneficial effects with proning patients? And if so, what is your proning protocol?
Yeah, proning patients has been shown to be beneficial. When you look at large randomized trials in ARDS, proning patients may actually influence survival and benefit some patients. Now, it's not a panacea and it's difficult. Some people use pronating beds that are rotating from dorsal to prone positions, but most people prone the patients on the bed themselves by flipping them. And there are challenges associated with proning patients, obviously, in the ICU. But the idea is to eventually allowing areas of an adequate gas exchange to be preferentially used in patients who otherwise would have recumbent areas of the lungs not participating efficiently to gas exchange. So we can prone patients for hours, but we eventually have to rotate them on a regular basis. The exact protocol would be best shared electronically so that, you know, I don't make deviation from the exact protocol.
Absolutely. Thank you. And I do have one or two more questions, but just to note, a lot of these questions are great, and we at Assist International will try to do some research into some of the resources out there, as well as connect with Dr. Massion on this, and post that information on our website at assistinternational.org. So let me just ask you two more quick questions, because I do know we're running out of time, if that's okay. One is, you said your inclination is to intubate early. We talked about this. If you're in a low resource setting and you have the ability to do CPAP, or I think it's BiPAP, BiPAP, should you, is there a risk of worsening aerosolization?
Yeah, the risk of worsening aerosolization is definite. So yes, it is a high risk. So, you know, that becomes a clinical judgment case, and whether you have an environment where you're able to isolate the individuals, whether or not there is negative pressured rooms or not. But in low-income countries, it's going to be very difficult. If it comes to trying to save somebody's lives, one has to use their own judgment to eventually apply what's best for the individual, and considering the matter of the healthcare workers that are supporting a larger population. So these are very difficult questions, and I'm far from a person who is going to make judgment on a decision in that space. I can tell you briefly in 1 minute that I had a difficult case of a patient in the ICU who ended up passing away. The patient had COVID-19, was intubated, had tremendous amount of airway secretions that we had a hard time to deal with. And the recommendation has been not to open the patient's circuit to air to prevent aerosolization and contamination to the healthcare workers. So we could not manage this patient efficiently, and unfortunately the patient, who had major comorbidities, passed away of airway obstruction related to heavy secretions we could not manage. So at that point, you ask yourself, should we disconnect the ventilator and suction anyway? We had a big debriefing with residents who were at the time involved in the care, and it was a very difficult discussion to have, and very important one, but very respectful of people's best intentions and behavior and judgment.
Thank you for sharing that. That must have been very difficult. One other question that came in, and I'm not sure if I understand it correctly, I apologize, but the question is, can the reproductive rate of the virus keep increasing, and more than, I guess, 4 times is the question?
Yes, it can keep increasing. The reproductive rate is easily conceived by, if you think that one person is infected
Nếu một người nhiễm
and is likely to infect 2 other persons,
thì có
suppose
thể
that
phải
person
lây
goes
cho
to a
2
meeting with
khác.
10 people, they're likely to infect many more patients. If they are in an environment, let's say like a
Nhưng mà trong một
sports
cái không
event
gian
where
vắng,
they'll be shouting
một
and
không gian
singing and
kín mà mọi người có những
exposing
hoạt động như là nói
the
năng,
air
hát
to
hò,
many
cùng với
other
nhau chẳng hạn.
individuals,
Con
the
số lây nhiễm,
infective
số lây
rate
nhiễm
may
này nó
go
có thể
higher
khác
than
nhau.
this. But these are average numbers we're talking
Đây là
about,
cái
and the
con
average
số trung
always
bình.
regresses to the mean and to lower levels. So a reproductive rate of 2 to 4 is pretty high already. What we want is to be lower than 1, to become in control of the infection. We have not reached that yet at our institution, and we're very close. We hope to be in that situation when we start getting control of the infection, which has happened already in China and many other areas.
Một số nơi thì đã bắt đầu có thể quản lý cái chuyện này rồi, ví dụ như là
I'm just going to ask you one more quick question, if that's all right. Have you seen any patients who had a stable clinical appearance talking without respiratory distress, but very low oxygen saturations? And if so, how did you manage them?
Làm thế nào để quản lý một bệnh nhân nguồn
I
oxy
have
rất là
had this
thấp?
many times, but not in the context of COVID-19.
Tôi thì đã quản lý rất nhiều bệnh
These
nhân
are
như này, nhưng mà không phải
very
trong cái hoàn cảnh
difficult
của
patients, and we
COVID-19.
have to watch them very carefully. People are sometimes very tolerant to low level of oxygenation, and they're definitely high risk. They may have multiple other reasons as to why that is. It could be some intoxication of some kind, some related heart disease, or some other respiratory abnormalities, including vascular disease that would be threatening. These patients needs to be watched very carefully and hopefully diagnosticated appropriately and quickly. In low and middle income countries, the deployment of non-invasive measures for diagnostics, including ultrasonography, has made a huge difference. And I'm a big proponent of training house staff, students, and attendings in that particular skills. It could be very much life-saving.
Và phải tập huấn cho nhân viên y tế càng cụ thể.
Thank you very much, and thank you very much for your presentation and for answering all of those questions. I know it was very beneficial for everyone on the call, and we are also, as we mentioned, going to be hosting this on our website, on the Vanderbilt Institute for Global Health website, as well as the Khmer and Vietnamese recordings. And so we know that this is going to be much more widespread than just the audience on the call tonight. Let me pass it back to you, my colleague Chase, to close up.
Thank you, Monica. Yeah, I'd like to thank you, Dr. Massion. That was very informative and very great. I'd like to thank our interpreters as well for making it possible to reach a wider audience. Before we go, we are going to put a QR code up on the screen for everybody, and that's going to link to a WhatsApp group that you can use to continue this conversation, to learn from each other if that's something that you would like to do. And then I'd like to thank you all for joining as well, and we look forward to having you on our future sessions.
Rất là cảm ơn mọi người đã tham gia cái buổi ngày hôm nay.
Thank you.
Thanks, Pierre.
My pleasure.
Thank you, Dr. Pierre.